Is this working? Can you hear me? Yeah. So, what are personality disorders? As we already discussed, they are rigidification of habitual behavior that implies both in general three types of rigidities. One, inhibition of normal behaviors. For example, a person functions very well but doesn't dare to speak in public, or doesn't dare to participate in a social group, or is afraid of sexual intimacy. Inhibitions. Second, exaggeration of certain behaviors, what we call reaction formations, trying to intensify behavior that is opposite that which an individual is afraid of. A person with a sexual inhibition acts very exhibitionistic. One of our patients, a young woman, goes around in a mini skirt with dramatically low openings in her dresses, talks all the time about sex, but when it comes to having an intimate relation, she's afraid, has severe sexual inhibition, and is the opposite of what she demonstrates in public. And third, chaotic alternation between inhibitions and exaggerations, so that there's a general contradictory, chaotic behavior of the individual, in which the patient jumps from one behavior to the next, trying to avoid getting into depth and showing rigidity mostly through chaos. And of course, once an individual develops such pathological patterns, it invites responses by others that are hostile, unfriendly, disappointed, questioning, and that reinforces the abnormal behavior rather than reducing it. And so it creates vicious cycles that become very dangerous. A patient of mine experiences every time that her fiancé doesn't do what she wants to do, as if he were no longer loving her. She gets extremely anxious and starts making demands. We were going to go out tomorrow. Why can't you? Is it so important what you have to do? She becomes so insistent that he finally gets irritated and says, you know, I love being with you, but I have to do other things as well. And that she feels a confirmation that he doesn't love her, so she's even more angry. Is that the way in which you respond to my interest, that you should come out with me when I love you? And she expects him then to be very loving while she escalates, so that it becomes a vicious cycle that ends up with a sea of tears and all kinds of misunderstandings, and threatens the relationship, of course. So the consequences are a reduction of the capacity to adapt to the psychosocial environment and to satisfy internal psychological needs of self-affirmation, sexuality, dependencies, and this tends to, as I mentioned, to be responded in ways that reinforce the pattern. Now, about the typology of personality disorders, this is a presently highly controversial issue, and it has importance because it influences, of course, diagnosis and treatment. Excuse me, I'm interrupting for a moment because I want to pick up my glass of water. Thank you very much. There traditionally has been a fight between two kinds of researchers in the field. The categorialists, there has been, traditionally there has been a fight between two kinds of researchers in the field. The categorialists and the dimensionalists. This controversy goes through the last 30 years. In my opinion, it is totally unnecessary and has to do with the rigidity of the researchers in the field. So I'm giving you my own opinion about this, but you'll see how this relates to what's going on right now in the classification of international ICD-11 and DSM-5, the American and the International Classification of Mental Disorders. The categorialists, mostly clinical psychiatrists and psychologists, tend to diagnose patterns of behavior that go together and form different categories of mental disorder. Of personality disorder, the borderline personality disorder, the paranoid personality disorder, the narcissistic personality disorder, etc. The dimensionalists believe that this is artificial, scientifically has an empirical basis, and that we should study all the characterological behaviors that exist, factor analyze them, and see how they go together. And the different personality disorders are simply different profiles of a continuum of various abnormal traits. The five-factor theory in psychology has been very important for the dimensionalists, who have tended, especially under the influence of Millon, who have tended to classify, to study 150 traits, study 20,000 people in the population, factor analyze, and come out with 5 major factors. Openness, conscientiousness, extraversion, amiability, and neuroticism. And these are the common traits, and personality disorders are simply different profiles along those traits. And so that there are personalities whose main problem is in the area of excessive extroversion or excessive introversion, excessive neuroticism, etc. So the dimensionalists are based on social psychologists who study large populations, while the categorialists are based on clinical psychiatrists and psychologists who actually see patients. The dimensionalists are reinforced nowadays by neurobiological researchers who find that certain basic behaviors are anchored in neurobiological functions, particularly emotional dysregulation, excessive activation of aggression, of anger, related to hyperactivation of the amygdala, affective dysregulation related to decrease in the capacity for effortful control, a specific rejection sensitivity based upon other brain areas, so that certain locations of areas in the brain are expressed in behavior, and when one finds a relation between a brain function and the behavior, then that shows that this behavior is a trait that depends on the brain function, and that leads us back to the study then of individual traits by factor analytic means, and the search of relating such traits that are anchored in neurobiology, which what is correlated in the study of patients and population with a 5-factor system. The categorialists, on the other hand, have started looking at the combination of typical behaviors in personality disorders, study the interaction of these patients and the existence of specific psychological conflicts in the areas of attachment or sexuality or play bonding or fight flight that these individuals have not been able to deal with, and against which they have set up specific defenses that constitute the descriptive aspects of personality disorders. In other words, the categorialists look for underlying complex psychological as well as neurobiological disposition, in contrast to the dimensionalists who like to go directly in isolated traits from neurobiology to behavior. So the big difference at the bottom is that on the one hand you have researchers who are interested in a neurobiological perspective and want to find neurobiological origins of the characterological rigidities, who combined with social psychologists who try to study socially dominant behavior patterns, but leave aside or ignore the intrapsychic subjective organization of behavior that is an essential part of the development of the personality and of personality functioning, in my view. In other words, we are dealing with a tendency to jump from neurobiology to behavior, bypassing psychological structures, to a concern with psychological structures, their underlying neurobiological features, but their internal organization at the psychological level, and then expression in behavior. This is the big difference. the extent to which subjectivity and the analysis of the structural aspects of subjectivity, the structural aspects such as the self-concept, that's a psychological structure. There is no neurobiology of the self, no area of the brain that you stimulate and you stimulate the self. Every time you start thinking about the self and study at the same time with various neurobiological instruments, the activation of specific areas of the brain, you find out that every time you think of yourself, there are 8 different areas that get activated simultaneously. Areas having to do with your place in space, your place in time, your linguistic capacity, the observation of the external environment, your usual view of significant others, your historical self. All these are different brain functions that get organized at the psychological level. And there are different areas in the brain in which these come together. The ventromedial part of the prefrontal cortex indeed is an area that tends to organize simultaneously all the neurobiological bases that are being brought together by the fact that you think of yourself. If you think of somebody else, the lateral part of the prefrontal cortex is activated, which specializes in the observation of the self. So I'm stressing the importance of studying psychological structures as intermediate between neurobiology and behavior. That's the big stone that's blocking the road of a large majority of researchers in the field. I'm sharing with you, of course this is not only my own thinking, but I'm sharing with you the view of a group of researchers very concerned with the study of personality disorders and who have contributed very significantly to the study of and treatment of personality disorders, in contrast to the ignorance really of clinical reality of the people who deny the existence of a subjective world. Proof of the pudding is that in my institute we developed the concepts that I presented to you about the organization of the self in the internal world of significant others, the concept of identity as integration of the concept of the self, integration of the concept of significant others 30 years ago, which was ignored by successive systems of classification. And only in DSM-5, 4 years ago, for the first time, the big news was that the central aspects of personality disorders are disorganization of the self and of the relation with significant others. Object relations theory was discovered as the essential aspects of personality disorders and is now a central part of the American classification of DSM. At the same time, the decision has been to maintain the profiles of some personality disorders for which there exists empirical research in the last few years and eliminate others for which there is no present research, which is absurd because the patients are the same patients and you don't eliminate the patients by eliminate the classification. So the paranoid personality was eliminated and the dependent personality and the schizoid, and the only thing left was the obsessive compulsive, the histrionic, the schizotypal, the antisocial, and the borderline. But in any case, those were left. The international classification is coming out with something worse. They're saying, now we are letting everything go. We'll just classify severity on the basis of severity of the self and severity of the self in the sense of lack of integrated concept of self and lack of a sense of self-direction, and problems of relation with significant others in the sense of lack of capacity for empathy and lack of capacity for intimacy. These are indeed essential criteria, which, as I mentioned to you, we knew for 30 years, and they couldn't be eliminated. But they are used to indicate severity of personality disorder, abandoning all effort of special categories in order to stay in a purely dimensional trait-based system. That's the decision of the International Committee, for which in a way picks up the best of what DSM-5 has developed, but drops very fundamental aspects of personality disorders. Before I go ahead, I just want to know whether what I've tried, the complex controversy I tried to summarize to you has been clear or not before we go on. If you have questions about it, it didn't seem clear, ask me. There was a recent yes, please.
Yes, I just didn't quite catch which of the groups were specifically occupied within neurobiology. Was that the categorialists or dimensionalists?
Excuse me, could you please repeat the question? I want to hear it from closer up.
Yes, I didn't quite catch which of the two groups of researchers that you mentioned that were specifically occupied within neurobiology. Which one of the groups? Because you mentioned the categorialists and
the categorialists are the clinicians who are studying subjective structure as well as neurobiological determinants. The dimensionalists are interested only in relating neurobiology with behavior in the form of individualized traits, bypassing the psychological structuring of the personality. Okay. I don't know whether any of you attended the recent Congress, the recent International Congress of Personality Disorders in Heidelberg, where the committee of the ICD-11 presented its presentation, and before the 500 people who are all interested in specializing in personality disorder, there was massive indignation in the room, but they didn't seem very disposed to listening, except that the borderline personality disorder was kept as one instance in which there's so much research going on that they didn't dare to eliminate it. On the other hand, it is clear that this is a temporary arrangement. I think in 10 years from now, there will be a general acknowledgement that we need both dimensional criteria, namely dimension of severity of personality disorder, and categorical criteria in terms of different clinical entities. But we'll talk more about this throughout the day. I've brought you up to the controversy. I must say, some of the people who have this problem are, on the other hand, very distinguished and admirable researchers in neurobiology. So that it is a group spirit that is the problem. A difficulty to acknowledge subjective structures, which is a kind of probably, this is a pure speculation, part of the spirit of the time that is directed against the study of subjectivity and individuality as if it were romantic, old-fashioned concepts, which is just a fantasy. So, with this introduction, the typology of personality disorders can be seen from a descriptive level, simply maladaptive traits, the DSM-4 axis, for example, and DSM-5 axis as well. That's the descriptive aspect. The structural aspects of the study of the personality refers to both the severity of the personality disorder, which is a dimensional aspect of all of them, and to the organizational, psychological, organizational aspects of these disorders. The intrapsychic structures, the profound structures, psychological structures that that underlie these descriptive features. And then there is a dynamic view of personality disorder, which has to do with the study of specific unconscious conflicts that they have. So these are three levels of approach to the problem. And I would say in general that a psychodynamic approach is not useful because the same human problems can be present in people with very different psychological structures. A purely descriptive aspect misses the degree of severity and the general organization of personality disorders in terms of treatment. So the combination of descriptive and structural aspects to personality disorder is really an optimal way of studying them and classifying them, and that's what we have attempted to do from an object relations viewpoint. I already mentioned that. This is the axis 2 on DSM-4 and DSM-5 before they were changed, and they were classified into cluster A, B, and C totally arbitrarily. There is no basis except that it was politically convenient for reasons that nobody remembers anymore. So having said all that, I'm now coming to our own view of personality disorders from the viewpoint of clinical diagnosis and treatment. And what we have done is to classify personality disorders first of all from the viewpoint of severity. Mind you, we did that for 30 years. It is only now that it is for the first time that aspect of severity is being included both in DSM-5 and ICD-11. First, normality, which means normal flexibility and adaptation, I have already described the characteristics of that to you. Second, neurotic level of personality organization. We talk about neurotic level of personality organization when there is a rigidification of behavior sufficient to create significant problems in the area of work and profession, love and sex, social life, creativity. But with a permanence of an integrated sense of self and the capacity for an integrated view of significant others. In other words, the person has rigidities of different types, but rigidities sufficiently significant to reduce function in one or several of these areas to warrant the diagnosis of personality disorders that are being treated, but with an integrated sense of self and an integrated view of significant others. That's what we call neurotic personality organization. I will talk more about how we diagnose that clinically seeing patients. Third, borderline personality organization, not to be confused with borderline personality disorder, which is characterized by rigidities with a tendency toward contradictory or chaotic character traits, and a lack of integration of the concept of the self and lack of integration of the concept of significant others. That's borderline personality organization, and of course there are various types of personality disorders that function at that level. And finally, there exists a psychotic level of personality organization which is not a borderline personality disorder, but refers to the fact of an underlying psychotic illness or organic disorganization of the personality, severe mental retardation or dementia, or a psychotic illness, schizophrenia, major affective disorder with psychotic development, paranoid psychosis, in which there is a loss of reality testing. In other words, a loss of the capacity to differentiate between self and others. And we'll explain a little more about that in a minute. So that the difference between these levels of severity is everything is fine with normality, identity is normal in neurotic organization, identity is lost in borderline organization, but reality testing is maintained, and reality testing is lost in psychotic personality organization. That's our basic clinical organization. Borderline personality organization, in addition to the lack of integration of normal identity, is characterized by what are called primitive defensive operations. A word about defensive operations. Freud had described defenses against unconscious conflicts. In other words, rigid habitual behavior patterns directed against the awareness of unconscious conflicts. Freud described particularly repression as a major mechanism keeping intolerable conflict out of conscious awareness, and mechanisms related to repression, such as intellectualization, rationalization, negation, reaction formation. These are the traditional mechanisms of defense I'm sure well known to all of you. Melanie Klein described primitive defensive operations that are all based upon the mechanism of splitting. The mechanism of splitting is a primary, probably neurobiologically determined function of separating idealized from persecutory segment of experience. And in borderline personality organization, in which there is a lack of an integrated identity, in other words, where there is split between an idealized and persecutory segment of experience, splitting indeed is a dominant mechanism that is reinforced by other mechanisms that Melanie Klein described that are projective identification. Projective identification is a primitive form of projection that consists in attributing to another person something one cannot tolerate in oneself, unconsciously behaving in ways that induces that behavior in the other that we are attributing to the other, and efforts to control the other under the impression that the other is controlled by that which we are projecting onto him. So projection plus induction plus effort of control combined constitute projective identification. It is different from projection, which is related to repression, in that in projection at a high level, one attributes something to another that one doesn't recognize in oneself. The individuals who hate homosexuals, no homosexual impulse themselves. That's projection based upon repression, no awareness of one's own unconscious reasons for hating homosexuals. In projective identification, one maintains empathy with what is projected. One knows what it is that one cannot tolerate and is projecting, so that it has a less efficient and more primitive quality. So in addition to projecting, inducing, controlling, one still maintains empathy. One still knows how it feels the way one thinks the other one feels. A very important mechanism with borderline personality organization. Another one is the maintenance of primitive idealization of some people, devaluation of others, or rapid shift from idealizing a person and devaluing her the next moment and going back to idealizing the person without these two ways touching each other. Omnipotent control is already implicit in projective identification, the need to control others to avoid the emergence of an intolerable conflict. And denial, which is a complex mechanism in which one is aware of a certain content but denies the importance. In other words, I know I have times in which I get enraged and furious and can't control myself and hit out people, but I don't feel any of this now. So it has nothing to do with me now. Something from other times. That is denial. It is maintenance of cognitive awareness or something that's emotionally completely split from what's present awareness. These are the primitive defensive mechanisms that go together with predominance of splitting and are typical for the borderline personality organization. Now, one way we can recognize these mechanisms is that the high-level mechanisms in neurotic personality organization don't show clinically. They only show under treatment as an effect of using free association to get the patient to start looking at his internal life, that those mechanisms, repression and others, become available. To the contrary, with borderline personality organization, those primitive mechanisms operate in behavior, manifest themselves behaviorally. So we see in inappropriate behaviors of patients these primitive defenses. A patient comes in, first session, and in the middle of this, patient interrupts, says, "So, why are you looking at me so ironically all the time, doctor?" That would be a manifestation of a behavioral distortion of reality, a projective mechanism, probably projective identification. One doesn't see that in patients with neurotic personality organization. It helps in the diagnosis, but it varies from patient to patient, while identity is very easily diagnosed. And finally, it says variable reality testing. That's probably not a good terminology. What happens is that reality testing is maintained, but the subtlety of social interaction gets lost with borderline personality organization. With neurotic personality organization, good relations with significant others, subtlety of awareness of social cues remains. In borderline personality organization, there is a loss of that, which leads to socially inappropriate behavior, not crazy behavior, but there's a loss of the kind of subtlety of getting social cues to understand how other people are reacting toward one or what the needs of a moment are. So reality testing is maintained but weakened. In contrast, in non-borderline personality organization, in psychotic personality organization, reality testing is lost. What's reality testing? It is the capacity of differentiating self from non-self, internal from external reality, maintaining empathy with social criteria of reality in one's affect, in one's thought, in one's behavior, and it can be elegantly and easily evaluated clinically. And we'll talk about how to evaluate that. Well, we can talk about it immediately. If a patient has hallucinations or delusions, reality testing is lost, obviously. If a patient has pseudo-hallucinations, it's not lost. As you know, pseudo-hallucinations are false perceptions in which the individual is aware of having false perception, and that we can find both in psychotic patients and in borderline patients. A patient may say, and then I saw the Virgin Mary in the corner, and I know that was she wasn't there, but I really had that impression. I heard my mother telling me, I knew my mother wasn't talking to me, but it was a very real experience. These are pseudo-hallucinations. In true hallucinations, the Virgin Mary was there, yes. It was no apparition. You have to believe me. Obsessive thoughts are pathological thoughts which the individual recognizes as such, clearly. Reality testing is perfectly maintained. Overvalued thoughts are false thoughts regarding which one isn't sure. Is it true or not? They still can be found in personality disorders. True delusions, false beliefs of an idiosyncratic nature that cannot be corrected by by anybody's reality testing, those imply loss of reality testing. So if a patient has no hallucinations, no pseudo-hallucinations, no overvalued ideas, no delusions, so he seems definitely non-psychotic, but he seems like a strange bird. There's something funny, strange about the person. We can't put our finger on it, but he doesn't seem to follow usual way in which ordinary people behave. One gets a feeling there is a loose screw somewhere. And what we do is, toward the end of the interview, we tactfully confront the patient with something that seemed to us strange or inappropriate in the patient's thought, in the patient's behavior, in the patient's affect. And we tell the patient, it seemed strange that you reacted this way, or I couldn't, something strange in your way of behaving or in your thinking. Can you see that what I just described to you seemed strange to me? And when reality testing is maintained, the patient is able to say, yes, I see your point, and gives us an explanation which makes that which seems strange more understandable. If reality testing is lost, the patient will not be able to understand that, will feel attacked. He may get temporarily worse. It is an elegant way in which you can make the diagnosis of an atypical psychosis. Borderline personality organization has a number of clinical consequences. What we call non-specific ego weakness, a generalized lack of impulse control, there's a primitivization of affects, loss of adequate affect control, a lack of anxiety tolerance, of course, serious disturbances in the relation with significant others, difficulties with work and love, and sexual pathology of broadly two types. Some borderline patients have a severe inhibition of all sexual functions. Those are usually more seriously ill, in which normal erotic functioning has been interfered with by an excessive predominance of aggression. And then there are others who have a wild sexual behavior, who on the surface seems much more ill, with a combination of heterosexual, homosexual, exhibitionistic, masochistic, fetishistic, sadistic, masochistic, voyeuristic, exhibitionistic, etc. All kinds of features, crazy life in their sexual behavior. They look sicker, but in fact, the prognosis is better because at least there has been a development of their capacity for a sexual life, that when their capacity for object relations improves, goes with it and then can be integrated into significant relations with others. And finally, there may be pathology of moral functioning in the more severe cases in which the system of moral values has not been integrated. Antisocial behavior develops, and that is extremely important because prognostically it is one of the two most important negative features for all kinds of psychotherapy. The more severe the antisocial behavior, the worse the prognosis for whatever kind of psychotherapy. So that one has to seriously evaluate antisocial behavior. We'll talk more about this when we talk about pathological narcissism tomorrow. Main causes of borderline personality organization. They are it's a complex etiology, no single pathway. There's a genetic disposition that affects abnormality of the neurotransmitter system, abnormal affectivity with predominance of negative affects, predominance of particularly aggression, and lack of normal affect control, which are temperamental features, and a history of chronic abnormal relations with significant others, blurring of generational boundaries, severe neglect in the first few years of life, sexual abuse, physical abuse, witnessing, chronic witnessing of physical and sexual abuse, and of course the pathology of attachment, predominance of insecure attachment with lack of normalization of affect disposition embedded into normal object relations. So that it's a complex combination of genetic, constitutional, temperamental, attachment, and early pathological environment etiology. The factors vary from case to case. This is our diagnostic interview. We now have all the elements. Just to test this, how many of you are familiar with this? How many of you are familiar with the structural interview? Okay, so it's a minority. Because if everybody was familiar with it, I wouldn't want to repeat it. That is our diagnostic interview for personality disorders. We start out as, I think I can signal this here. Yeah, we start out, we usually start out telling the patient, I'm Dr. So-and-so. Thank you. I'm Dr. So-and-so. What I know about you, and we tell the patient everything we know about the patient so that he knows what we know, what we have heard about him. We'll try to be very straight, or we can tell him I know nothing about you except name and your age or whatever. And then we ask him 4 questions together. First, we ask the patient, what brings you here? What's the nature of your difficulties? What do you expect from treatment? So where are you now? We ask that together. Notice, what brings you here? It's a very concrete, direct question. Patients should be able to answer it if they are cognitively okay and not really psychotic. The second question, what's the nature of your difficulty, is already more complex. It's less structured. And we invite the patient to give us a full information about physical, emotional, social symptoms. And we explain to the patient, if necessary, after he tells us 1 or 2 things, do you have any other difficulties? No. If you didn't have the difficulties that you told me, would you be perfectly all right? Well, who is ever perfectly all right? Would you just functioning normally without having to come and see a psychologist or a psychiatrist? And the patient then may say, well, I also have this problem and that problem. So we ask until we really get a full inventory of all the symptoms. let me stress the importance of that, to do really a full inventory of all the symptoms, because symptoms change throughout time and they are helpful in making a diagnosis. The third question, what you expect from treatment, is pretty obvious. Does the patient have any expectation? Does he come thinking, well, I thought you might help. I don't know. I was told to see you, that's all I know. So that's very different from a patient who says, well, I hope you will understand, you will help me understand why I'm behaving this way and what I can do to change. A very different level of motivation. And finally, the question, so where are you now, is totally open and leaves itself to be filled by the patient. So we go to very concrete questions, quite abstract ones, and with this gives us a first picture then of symptoms, and then we go into evaluation of the personality, and here is where we ask the patient to tell us how is he functioning at work and profession, at love and sex, social life and creativity. This is the center, really, of the structural interview. And we go into all details, and of course this requires sophistication to work. Ask what the patient is doing, finding out whether that corresponds to his level of education. Is he really working at his level, or is he working below his level of education? How does he get along with colleagues, supervisors, subordinates? Is he floating? Is he simply exploiting the family? By the way, I forgot to tell you, I mentioned to you that the severity of antisocial behavior was one of the two most important negative prognostic indicator. I neglected to give you the other one, which is secondary gain of illness, meaning that the patient is exploiting his difficulties and symptoms to be taken care of, either by a wealthy family or by the state. It is a very frequent complication in the treatment of severe personality disorders, that they develop ways in which everybody's paying for everything. Typically, the patient starts out saying, whenever I have to go to work, I get anxious. As long as I can stay home, I feel okay. That's a danger signal. There is no reason why patients with personality disorder can't work. Patients with borderline personality organization, severe personality disorder, should be able to work or study. And there are long-term efforts to avoid that while having others taken care of them is a major source of negative treatment outcomes. So that, together with antisocial behavior, bad prognostic indicators. When it comes to sexual life, we ask the patient whether they have a stable relationship, whether they have ever been in love, whether they are in love now, whether they combine sex and tenderness, or whether they have to keep them strictly separate. Obviously, the questions have to be addressed differently to people at different gender and age. We ask a 12-year-old different question, a 12-year-old boy different question from a 30-year-old woman. So they have to be geared, obviously, to social and age reality. Same regarding social life, varies for somebody who goes to school, elementary school, high school, university, or is in the middle of intense work in industry. So this we spend enough time to really get to know the person. What we do with our students is we tell them, imagine you are on a cruise through the Mediterranean, it's night, a romantic night, you meet somebody, looks like the person for the rest of your life, and you want to know quickly what kind of person is that? What kind of questions would you do to find out? So we try to find out about patients as if they were the one with whom we're going to spend the rest of their life. We really want to know them, and this is our chance to do that. And then we evaluate identity. I told you that we were going to do that. What we do is we ask the person, now that you have been describing to me the most important people in your life, because when the people talk about their present life situation, they talk about the person with whom they live, or the parent, whoever are the most important people with whom they pleasantly relate. If they have not mentioned anybody, we can ask the person, who are the most important people in your present life? And we'll tell, in your present life. And then we ask the patient, can you describe that person to me in a few minutes so I get a live picture of that person? And we ask them to give us a description of that person. And then we ask them to do the same with one or two more people. It's not easy. Ask yourself if you have to describe the most important person in your life. But if you have only a few minutes, some essential things will be coming to mind. But you'll have to think and then say something that is obviously significant. And patients with identity diffusion are incapable of doing that. So their descriptions are totally cartoon-like, empty, cliché. They don't permit you to get any real feeling. And if they describe 2 or 3 people, they may say the same thing. A patient tells you, oh, my mother, she's a very nice, dedicated person. And she does everything for me. We get along splendidly. So we ask, well, what about her personality? What makes her different from other people? Oh, she's great fun. Sometimes she can get very angry. You can see that's very different from somebody who tells you she's very concerned about those around her, but so worried about her own issues, about illnesses, that the worry looks more like trying to tranquilize herself than really taking care of others. And everything has to be rigidly the way she wants to, then she can relax. You see, that's a very different kind of description. After we have asked the person to describe 2 or 3 others, and only then we tell them, now, how would you describe yourself? What makes you different from anybody else? What's unique about your personality? And again, we can get a very rich description or one that is totally empty. It is not a diagnosis difficult to make, but it requires clinical practice. Reality testing you can do walking out of this room. It's a very simple method. The evaluation of identity requires practice. And the way we help our students to acquire that practice is we have them seeing our sickest patients with severe borderline personality organization, and then to ask the questions about identity to their friends, telling them that they are studying personality, and could the friends do them the favor to describe the most important people in their lives and themselves. And so our students can differentiate hopefully most of the friends and social life of our patients are not patients with severe personality disorders. So they notice the difference, and that in a few months gives that skill. It is crucial for the differential diagnosis of severity of the personality disorder. And finally, we test, reality testing, as I described it to you, to sort out the possibility of psychosis. If the patient turns out to be psychotic, then we go into traditional interviewing and study the patient's behavior, the patient's affects, the patient's thought, whether there are positive psychotic symptoms, or if we have an acute psychotic syndrome, then we study, of course, the sensorium, attention, orientation, consciousness, comprehension, judgment. Or if the patient seems mentally retarded, what is now called intellectually disabled, we study memory and intelligence. Usually it's useful doing a simple intelligence test if you need that, in addition to what the history gives you about where the person stands in their intellectual capacity, and of course a few simple memory tests will give you the information. If you have somebody with an acute, and so you can differentiate people who have a psychotic illness with a total disorganization of the personality, of typical psychotic symptoms in these areas, from those where the main problems seem loss of memory and intelligence, either primary mental retardation or secondary because of dementia. So you are really here in the role of classical psychiatric evaluation. And if you're still not clear, you can again go through the circle. And as you can see, your findings differentiate people who have a personality disorder, non-borderline, from those who have borderline personality disorder, from those who have a psychosis, or an acute or chronic organic mental disorder. That's the structural interview. It takes, in healthier patient, about 45 minutes with, but it's ideally one should give oneself for the first interview an hour and a half. Sometimes one can't reach a diagnosis. We may give patients 2 or 3 hours and a half interviews before we can make a diagnosis. But usually with this method, within that time, one can make an adequate diagnosis. Don't get frightened by this slide. It is our overall organization of personality disorders in terms of severity. Here you have neurotic personality organization, usually obsessive compulsive personalities, depressive, masochistic, hysterical. All these are borderline personality organization, higher level borderline, lower level borderline. Among the higher level borderline, the avoidant, the dependent, sadomasochistic, the histrionic, which is a regressive form of the hysterical, and the borderline personality disorder proper is really a regressive form of the same line that goes from hysterical to histrionic to borderline. Another important group is the narcissistic personality disorder that has a broad level of functioning. We'll talk about this tomorrow. And the most severe form of it is malignant narcissism, and even more severe, the most severe and untreatable personality, the one that can't be treated, is the antisocial. All these are extroverted personalities. These here are the introverted one, the obsessive compulsive, avoidant, and among the severe ones, the paranoid, schizoid, hypochondriacal, and psychotypal. Psychotypal is a more severe form of the schizoid, and the hypochondriacal personality is a rare but important personality disorder in which there's a reduction of all social contacts, concern with one's body, imaginary illnesses, and an underlying paranoid orientation. Very difficult to treat. So as you see, we have severity on the vertical, introversion, extroversion on the horizontal, and in general at the severity predominance of problems around aggression, and at the less and particularly at the neurotic and upper level of borderline very often important component of sexual difficulties that predominate clearly at the neurotic level. If you have any questions about this, I'll be glad to answer that in the question and answer period. And now we go into just general overview of treatment. First of all, psychopharmacology. Psychopharmacology has an auxiliary function. It is contraindicated as exclusive treatment of personality disorder. You will hear the same from any good psychopharmacologist. It can help particularly with the symptoms that frequently are an expression of severe personality disorder: chronic anxiety, characterologically based depression, impulsivity, dissociative reactions, and they can be treated by SSRI and SNRI antidepressants. We don't use other antidepressants because these are the safest one to prevent the use of them for suicidal purposes. Low-dose neuroleptics, atypical antipsychotic medications that are very effective to reducing severe anxiety as well as characterologically based depression, and mood stabilizers, which usually don't have indication to start as first indicated, but are particularly helpful in patients with very intense, severe, aggressive outbursts. There they have a definite place. It is important that if a patient gets psychopharmacological treatment, that if the psychopharmacologist is different from the psychotherapist, that the two maintain a team approach, that they know each other, that they are in sync. In other words, that to avoid that the treatment of the patient is split between the two. The most important part of the treatment are psychotherapies, and there is empirical evidence both for the effectiveness of cognitive behavioral psychotherapies, particularly dialectic behavior therapy has a tremendous empirical basis showing its effectiveness. To a lesser degree, schema therapy or the traditional cognitive therapy by Beck. Among the psychodynamic, there exists a psychoanalytically oriented supportive psychotherapy. We'll talk briefly about that. Mentalization-based therapy developed by Bateman and Fonagy, in which the main objective is to help people obtain a clearer sense of their own mental states and motivation and that of other people, to reduce the pathology directly in the interviews of the assessment of self and other interaction, and Transference Focused Psychotherapy, which is the psychotherapy we developed in my institute, and which is the only one that attempts to change the personality proper. In other words, rather than treating symptoms, we are trying to change the personality. That's the main subject for the rest of the day. I will try to give you an overview of our treatment. I already mentioned the theoretical underpinning of transference-focused psychotherapy, psychoanalytic object relations theory. Here you have our basic model of the dyadic building blocks of self and other linked by a dominant affect. And here you have the nature of mental organization before integration of identity, in which you see this is the primitive organization in the first few months of life, and going into the third year, in which you have a completely separate, in which you have a completely split separation between positive and negative internalized unit. You have just two of them on each side. You have to imagine many thousands. And of course, once normal identity is established, you develop an integrated sense of self and an integrated sense of others, in which positive and negative things, not negative affects and evaluations coincide, a self surrounded by an internalized world of object relations, and that constitutes normality. When that is not achieved because of the strong predominance of the negative segment, then this organization is maintained. Identity diffusion, normal identity, neurotic personality organization. The main concept underlying transference-focused psychotherapy is the psychoanalytic concept of the development of transference. What is transference? It is the unconscious repetition in the here and now of unresolved, severely conflictual problems of the past. If we don't have significant unresolved problems from the past, we still are a product of our past relations. So we still are disposed to express transferences in our pathological or in our unavoidable rigidities. But the mutual rigidities of all of us tend to neutralize each other. So we force each other to behave appropriate socially. Only in our most intimate relations do we dare to become neurotic. And in every intimate relations, there are neurotic elements. Andre Rune, some famous psychoanalyst, talked about the private madness, the private secret madness of all perfect couples. But of course, when there are severe unresolved conflicts with severe distortion of the personality, the pressure from this past emerges very powerfully. Now, this internalized relation with others are not literal representation of past relations, but they are modified by our fantasies and defenses. And in borderline patients, as you now know, the internal object relations have been segregated into idealized and persecutory ones, so that we have to be prepared that patients get into very idealized and mostly persecutory relations in intense treatment. We have to prepare to deal with primitive anxieties and aggressions. And how to deal with them and use them to help the patient normalize, that is the basic task of the treatment.